So today we will be discussing the Neurology CMS Form 3 that is created by the NBME organization, and these are subject specific NBME forms. So we already have two videos explaining, one video explaining surgery and another one which was our first video in this series explaining the family medicine form. Now these forms are actually done after your first pass of the QBank, preferentially UWorld or Amboss, whichever you prefer. After you complete the first pass of the QBank, then you will move on to the Clinical Mastery Series forms or the CMS forms in abbreviation as we call them. And these are basically there to provide you a general framework of how NBM intends to ask the question. So once you do the CMS forms, you would basically have an idea of uh, the pattern that the NBM uses to ask the question, which is quite different from what you will see in the QBank. So this will be a good change in pace, and also this would be good for you to practice with, so that you could grasp the NBME material in a better way. Now we will discuss this in a question answer format. There is explanation provided by NBME themselves for every form. There is an answer PDF also that provides the specific explanation of the particular question. But that explanation is not up to the mark, or I would say very high yield. So if you want to study and review high yield material, then this video will help you. This series will help you throughout, and this will not artificially inflate your score on the CMS forms. This will just give you the material that you must remember in order to perform better. So this is the material that is frequently asked in the paper. So if you are remembering the material that is frequently asked in the paper, then you will then obviously that will be better for you, and that will not artificially inflate your score because you in the end you know the material that is important for you. So let's begin. So the first question is: a 25-year-old woman presents with multiple growths on her lip, tongue that have been present for several years. Physical examination reveals nodular lesions on the lips, buccal mucosa, and tongue, along with numerous cafe au lait, macules, and cutaneous nodules over the trunk and extremities. This patient is most likely to develop which of the following tumors: craniopharyngioma, ependymoma, lymphoma, optic nerve glioma, pituitary adenoma. So I sort of tried to keep it a bit simple for the first few questions. So basically, what the question is saying is that the woman is presenting with growths on her lip and tongue. So these are mucosal growths, right? Now, first we need to identify the condition that the woman is presenting with. So these findings, the all of the findings that are present in the question, such as the mucosal growths. So those growths are known as mucosal neurofibromas. These are basically present where the mucosa is present, such as the lips, the tongue, the oral mucosa. Then there is also some nodular lesions and numerous cafe au lait macules. Now they may not mention the cafe au lait macules. They may simply mention hyperpigmented spots, and they may simply mention superficial nodules. So that's how they might change the wording a bit to confuse the candidate. But you must understand. Now, I've made it a bit easier in this question. I've written cafe au lait macules directly, although they can write hyperpigmented macules as well. So, hyperpigmented macules or light brown patches on the skin would be known as cafe au lait macules, and the mucosal outgrowths are the mucosal neurofibromas, right? So there are also certain other findings such as the cutaneous nodules or the trunk and extremities. These cutaneous nodules are the multiple cutaneous neurofibromas. These are basically soft, fleshy nodules. So there are neurofibromas on the mucosa, and there are also some neurofibromas on the skin and other parts of the body, where not specifically on the mucosa. So those are cutaneous neurofibromas, and the ones that are present on the mucosa are the mucosal neurofibromas. And you also have inguinal, axillary or inguinal freckling. You also have Lish nodules, which are iris hematomas. They are basically tumors that will be seen in the iris of the eye. And there may also be the family history present. So this constellation of findings is pointing towards neurofibromatosis type 1. Right? So basically we've identified the condition. Now we have to identify the associated answer with it. Now it is important that you must remember this constellation of findings. I have some pictures also to clarify it, but it is important that you know this constellation. So the gene, if they ask, is the NF1 gene on chromosome 17, and you have to remember this completely, not just the NF1 gene, but also which chromosome it affects. They tend to ask minor details in the paper. And the protein which is affected is neurofibromin. So I don't think that's difficult to remember, since neurofibromatosis and neurofibromin sound quite familiar. It is basically a tumor suppressor that downregulates RAS activity. So once it is affected, it won't be able to do its work properly. And as it is a tumor suppressor, if it is not working properly, then it would not suppress the tumor, and then there would be basically a cancerous or tumorous growth. So neurofibromatosis type 1 is a cancerous kind of a condition. So this is the cafe au lait spot, and this is not necessarily hyperpigmented, but just to keep it simple, I tell my students that this is a hyperpigmented spot, because it would be quite clear, no matter what skin color or skin variation there is. This spot would be quite clear. So you must keep in mind that they might describe it by various descriptions, but in the end, the basic concept remains the same. And this is the Lish nodules. So not mentioned in this question, but Lish nodules are iris hematomas. You can see that you can see these soft, these dark, round shapes. So if I must, you can see this shape, and you can see this one, this shape. You can see it. You can see these. You can see these. So these are basically iris hematomas. They are quite visible, so you don't need to worry about them. So they might give you the diagrams, or they might give you the description. As usual, you know what to do. Now, once you've identified the condition, now you have to identify the associated complications with it, such as there is an increased complication of CNS and peripheral tumors in NF1. Particularly, the three most important that you must know are optic pathway glioma, which is the optic nerve glioma, if you can understand. You see, optic nerve glioma is the most characteristic. If they ask you what is the most common, then optic pathway glioma is the most common, the optic nerve glioma. So the patient can also face pheochromocytoma in this condition. And there are also some other gliomas and meningiomas mentioned in your first aid book, but they're not really characteristic. The optic glioma is a low-grade pilocytic astrocytoma. You must know this because they might mention optic glioma in the question, or they might mention its counterpart description, which is the low-grade pilocytic astrocytoma. Both of these are same, so they can mention any description, and you must know both of them. Right? This is the most they can do. That's how they make the question more confusing. Is to just put synonyms in the question. So this won't be given as an answer, but this will, and some students might not recognize the trick that they are doing. So They are common in childhood but can persist into adulthood, and they might cause vision loss or proptosis. So these three tumors complications you must know with neurofibromatosis type 1. Now, why the other options are wrong is because it cannot be craniopharyngioma because it is associated with calcification and growth retardation in children. So it is not a craniopharyngioma. It is a childhood disorder. It cannot be ependymoma because it is seen in the fourth ventricle and it is associated with neurofibromatosis type 2. This is important to remember. Neurofibromatosis type 2 has its own constellation, uh, such as bilateral schwannomas, ependymomas. So it has its own constellation that you must know. It is not associated with neurofibromatosis type 1. Lymphoma is not associated with any neurofibromatosis, and pituitary adenoma is associated with MAN1 syndrome, not NF1. So the correct answer is the optic nerve glioma, which was option D. And key takeaway is that there were cafe au lait spots, neurofibromas, and niche nodules, which increase the risk of optic glioma and low-grade astrocytoma. Moving on, a 57-year-old woman presents with a 3-month history of gradually progressive weakness involving her shoulders and hips. She has a history of hypothyroidism managed with levothyroxine and is otherwise healthy. Vital signs are normal. Neurologic examination reveals moderate bilateral weakness of the deltoids, biceps, triceps, psoas, gluteal, and quadriceps. Muscles, sensation, and reflexes are intact. Lab studies show an erythrocyte sedimentation rate of 85 millimeters per hour and a serum creatinine kinase level of 2,456 units per liter. The complete blood count and urine analysis are normal, which of the following is the most appropriate next diagnostic step. So, again, you have to identify first what the condition is. So, the ESR is increased and the serum creatine kinase is very high, and the patient is having proximal muscle weakness. She also has a history of a autoimmune disease. So, these are some main clues that might guide you towards the final diagnosis. So, I'll wait a bit for you to think about this yourself and then we will discuss this. Okay. So, you have to identify the question pattern. Proximal weakness, shoulder and hip muscles would be mentioned in the question. So, you have to identify that there is proximal weakness. And so, there is no sensory involvement, which also rules out neuropathy. The CK is high, which indicates that there is a muscle inflammation or damage. And the ESR is high, which indicates that there is a systemic inflammation, although not very predictive, not very specific, but it is present either ways. So you must know what it means. So the pattern strongly suggests that there is an inflammatory myopathy going on, since there is no other cause of muscle weakness. They are clearly pushing you towards myopathy, and they are clearly pushing you towards the muscle problem. So there is no other etiology here except for looking at the muscle itself. So there is an inflammatory myopathy, and there are two main ones such as polymyositis and dermatomyositis. Now, why we are excluding other causes is because if there is a thyroid myopathy, the CK is usually only normal or mildly increased, and the patient is already on thyroxine and is euthyroid, so thyroid myopathy will not be there. It is either present in hypothyroidism. Usually, it is present in hypothyroidism, can be present in hyperthyroidism, but the patient is on medications and is euthyroid, so very unlikely that the patient is facing with a thyroid myopathy. There is steroid or statin myopathy that we're not considering because there is no history of drug use, no mention of steroid use or statin use. There is neuropathy or myasthenia gravis, which can happen, but we're not considering since myasthenia gravis would show progressive fatigability, and a simple neuropathy might show also sensory changes, but there are no sensory effects in the question. There is only motor weakness, so it cannot be a neuropathy. It must be contained within the muscle, whatever the pathology is. And we're not also considering a spinal cord lesion. Why? Because again, the spinal cord lesion would also have sensory deficits. So this is how we rule out other causes that come into our brain. Of course, these are not mentioned in the options as well. These are not mentioned in the options, but somehow these all of these options can relate to these differentials. So in your mind, you must pick out that this would not work. These causes would not be applied here in this situation, although may be applied in other situations. So the diagnostic approach to inflammatory myopathy is that you need to go with a stepwise evaluation. So first you need to take labs. The first is CK, of course. This is very important. CK is specific, it is particular, and it is clear for muscle damage. But they tend to ask the next best test, and they might not give CK in the question. So you go towards aldolase. Aldolase is the second option if CK is not in the question. So you go towards aldolase, which is present inside the muscle. And once there is muscle damage, the aldolase comes out into the bloodstream. So it can focus on the muscle damage. After that, because CK is already given in the question, so we would skip this step. After that, what the question is asking us is this step, the next step, which is the second step, basically. So the first is already done in the question. They've given us the CK. If I could show you this, they've already given us the CK. So now what they're asking us to do is answer what would be after the CK. So then we would do electromyography and nerve conduction studies. That will be the answer because it helps confirm a myopathic pattern. All right, and then to confirm it, we do muscle biopsy. So there are three questions from this that they could ask you. The underlying situation might be the same. They might give you an inflammatory myopathy, but they can ask you the first step or the first test. That would be the labs. Then they might already give you the labs, and then they may ask the next best step, which is the electromyography and nerve conduction studies. Or they might ask you how to confirm the condition. What is the way to confirm the condition? How would you confirm the condition? If they mention the word confirm, then you must choose the muscle biopsy because it is definitive and it gives you the confirmation. Now you must remember what they show you, what these tests give you in the result as well, because instead of mentioning EMG, they might say that what, so the next best test is applied, and what would be the result that would uh, confirm the diagnosis. So they are implying that the muscle biopsy is already done, but what would be the result that would confirm it? So the result would be that the endomysial inflammation would be present in polymyositis, and perimysial inflammation would be present in dermatomyositis. Endomysial in polymyositis and perimysial in dermatomyositis. On the EMG, if they already implied that the EMG is done, and what would the EMG show? If that is what they're asking, it would show a myopathic pattern, which basically just comprises of short duration, low amplitude potentials. That's it. To be very simple, that's it. So they could ask you in reality five different questions. So they could ask you first three from these steps, and then they might ask you two more questions on the pattern that these tests are showing. So you must understand and know all of this. So the correct answer, of course, is the electromyography and nerve conduction studies. The takeaway for you is proximal muscle weakness plus a high CK, ESR, no sensory deficit. It's obviously an inflammatory myopathy. The next step would be to do an EMG or an NCS to confirm the myopathic process, and it's muscle biopsy is basically for confirmation. This is to just uh, to give you an association with the diagnosis. That's it. So that's what you need to understand. All right. So a 24-year-old man is brought to the emergency department after sustaining multiple injuries in a motor vehicle crash. He is initially responsive but becomes progressively less alert over the next 45 minutes. Examination shows a dilated left pupil and ptosis of the left eyelid. He develops hyperventilation. Which of the following is the most likely cause of this condition? And these are your options. So go ahead and decide an answer. All right, so hopefully you've read this question. Right, so first of all, we need to identify what the key clues are given in the question. So I've also highlighted a few, and something that you want to keep in mind is that you always want to look at the age and mostly what setting is the patient presenting in. Such as in this case, this is the emergency department, but there could be the clinic or the office in some cases, which means that the patient that is presenting in the emergency obviously has more acute case. So whatever uh, management you choose for that patient, you have to make sure that aligns with the acuteness of the injury or the problem. All right. So first, you need to identify the key clues. So unilateral dilated pupil and ptosis is pointing us towards the compression of cranial nerve 3, oculomotor nerve. Now, what in what conditions does this happen? If you ask yourself, then most of these written here will be excluded. So, uncal herniation is causing the ipsilateral cranial nerve palsy. If you can read the question, it says that he has sustained multiple injuries in the motor vehicle crash, right? And they're saying that he has a dilated left pupil and ptosis of the left eyelid. So there is a history of trauma. That is why we can go towards the uncal herniation part. Now, why does this happen? It's because the medial temporal lobe or the uncus, we better know it as, herniates downwards through the tentorial notch and it compresses the cranial nerve 3. Now, it what also can happen along with the cranial nerve 3 compression is that the ipsilateral PCA might be compressed and an occipital infarct can occur, although it occurs later, but it can occur. And the midbrain can also be affected, which can lead to a decreased consciousness in the patient. So the patient is uh, going towards decreasing responsiveness. So it also fits the midbrain compression part. You can read that he is initially responsive but becomes progressively less alert over the next 45 minutes. So looking at these clues, it is a very subtle point that is presented in the question, but a very easy question nonetheless is that there is a history of trauma, and then there is decreasing responsiveness, and then there is the dilated left pupil and ptosis of the left eyelid. So you can go towards the fact that this is a neurological injury after trauma. So if you even get to that point, most of these options will be eliminated, right? It's very easy to go to the right answer after canceling the other ones. So why is the patient hyperventilating? It's because hyperventilation is also a pathognomonic sign of brainstem involvement and increased intracranial pressure. And uncal herniation, because it is an herniation, decreases the ICP rapidly. So you have to remember that hyperventilation is a sign of brainstem involvement. Now, to exclude other options, you can see that these all are uh, rapidly excluded because they do not cause isolated cranial nerve 3 palsy with rapid decline after trauma. But there are other options such as the central herniation. Now, what does central herniation cause? It causes bilateral small pupils, not a unilateral defect. And there is also infratentorial lesion. They could cause cranial nerve findings, but it is not acute after a trauma with unilateral blown pupils. So I'm going to show you the different herniations in a minute. I have a good illustration for it, but this is how you cancel out the options and get there. So the correct answer is uncal herniation, and trauma plus rapidly decreasing consciousness plus unilateral dilated pupil is uncal herniation. The mechanism is uncus compresses the cranial nerve 3 and gives a dilated pupil and ptosis, and later compresses the midbrain, which gives us the altered mental status and abnormal breathing. So this is an illustration for different kinds of herniation. We could start with D. This is the foraminal herniation, which the tonsils of the cerebellum herniate through the foramina magnum, and it of course gives other symptoms. A is the uncal herniation. As you can see, this is the tentorial notch. If I could show you, well, this is the tentorial notch. So it is herniating through here, right? B is a central herniation uh, through here, and C is a transfalcial. So this is the false cerebri, and the brain matter is herniating this way. So this is known as a transfalcial herniation. Now, most of these herniations give a similar presentation. It's not that there is a different presentation altogether. Most of these give a similar presentation, but at this level, what you need to understand is that you need to know the uncal herniation presentation, which we have done, and you need to know the central herniation presentation, which we have also done. Infratentorial is not really that much important. So I hope this is clear. Moving on. One day after an elective cholecystectomy, a 67-year-old woman becomes confused and agitated. She has a 2-year history of mild Alzheimer type dementia and is not taking any medications. She is given intramuscular haloperidol, and about an hour later, she develops repetitive neck hyperextension and involuntary repetitive upward deviation of the eyes that she is unable to control. Physical examination is otherwise unremarkable. Which type of medication would be the most appropriate treatment? Anticholinergic, antidopaminergic, anticytonergic, cholinergic. So, what is happening here? You must know this, must be able to identify. So, I'm giving you some time to figure this out. Right, so you can obviously see that this has started after taking haloperidol, right? The repetitive neck, hyperextension, and involuntary repetitive upward deviation of the eyes. This has started after taking the haloperidol, so this should be very, very clear. So what is happening is that she's undergoing an acute dystonic reaction. This is acute dystonia. Dystonia means that there is constant contraction of a muscle. That's what dystonia is simply. However, it is an extrapyramidal symptom due to the dopamine blockade in the nigrostriatal pathway. So you need to understand this is a nigrostriatal pathway that is being inhibited. That is why these symptoms occur. Common dystonic reactions are torticollis, that is neck extension and twisting, which is happening in this patient. There's oculogyric crisis, eyes stuck upward. This is also happening in this patient. Jaw spasms, tongue protrusion, opisthotonus. Opisthotonus, I hope you understand, is the hyperextension of the back. So the patient is like this, right? This is the head. This is the feet. These are the hands. So the patient is like this. He's hyperextending the back, right? The onset is from hours to days after starting or giving dopamine blocking agents. In this case, it's haloperidol. One thing that you should know that the dopamine blockade in the nigrostriatal pathway leads mostly to the uh, adverse effects of the typical antipsychotics, the first generation antipsychotics. But there is another pathway. Due to that pathway's blockade, the actual efficacious effects of the uh, typical antipsychotics occurs. So there are different pathways. We could even see mean blockade pathways of haloperidol. Right. So this is the pathway. So you can see that there is a nigrostriatal pathway, there is tuberoinfundibular pathway, there is mesolimbic pathway, and there is mesocortical pathway. Right. So if I could get a better picture, this is not a better picture. This is a better picture. Nope. Let's go back to that one. Right. So due to the blockage of the nigrostriatal pathway, the side effects occur. Right. But due to the blockage of the mesolimbic pathway, there is the due to the blockage of this pathway, the medicine is actually able to work, right? So the good effects of the typical antipsychotics occur due to the blockage of the mesolimbic pathway, but the bad effects occur due to the blockage of the nigrostriatal pathway. So I hope that is clear. I hope that is clear. Yeah, this is the better picture. So nigrostriatal pathway gives rise to it controls the motor movement, and it gives rise to the extrapyramidal symptoms. You can see, right? The mesolimbic pathway is associated with the memory and the positive emotions. Now, there is also the tuberoinfundibular pathway, which controls the prolactin secretion. It controls the prolactin secretion. For some reason, it has went away. Let me get to it. There was a very good illustration. Anyway, so let's let's uh, let's try to do it without the illustration. So what happened was is that the tuberoinfundibular pathway is this pathway is basically controls the prolactin secretion. So if you're giving antipsychotics to a patient and that patient goes into hyperprolactinemia because dopamine is being blocked, so there would be increased secretion of the prolactin. This pathway would be the culprit. If the patient is undergoing extrapyramidal symptoms, this pathway would be the culprit, nigrostriatal pathway. And if they're asking why, due to which pathway, there is the efficacious effect of the medicine, so you would go for the mesolimbic pathway. But do confirm the fact that it is the mesolimbic pathway that is due to that gives rise to the positive effects of the medicine. I am not confirmed on that, but I am confirmed on the nigrostriatal and the tuberoinfundibular pathway. So please confirm that from your own side as well, right? So you need to know that This is important, that different pathways are important, so you need to remember them. All right, so in the treatment for this is to restore the dopamine acetylcholine balance in the basal ganglia. What happens was that haloperidol decreases dopamine and increases acetylcholine, which increases dystonia, gives rise to dystonia because acetylcholine is a neurotransmitter that increases the contraction of the muscles. So therefore, the treatment requires anticholinergic medications, which introduce the balance in neurotransmission or reintroduce balance in neurotransmission, I should say. Best options for this treatment is benztropine, IV or IM, or you can also give diphenhydramine. And they tend to ask this because people don't consider this a typical anticholinergic medicine, but it has a strong anticholinergic activity. Although it is antihistamine, but it has strong anticholinergic activity. So benztropine is first line, but you can also give diphenhydramine. So the answer is anticholinergic. And why are the other choices wrong? Because antidopamines would worsen the EPS, and anticholinergic are used for serotonin syndrome, not for the extrapyramidal symptoms. Cholinergic would also worsen dystonia. And dopaminergic are not really first line because they don't directly target the muscle. All right, and cytonergic obviously are not related to the extrapyramidal symptoms. So acute dystonia after haloperidol, give IM, IV benztropine. And you can see there's a picture of a child, and this is the torticollis sternocleidomastoid with contraction. Right. This is a typical posture that the baby's head would be diagonally looking this way, and one neck would be contracted, and the other would be relaxed. All right. So a previously healthy 32-year-old woman presents with a 1 week history of positive, progressively worsening sensory loss. It began as a numbness in her feet and has gradually ascended symmetrically to the level of her umbilicus. She also reports urinary urgency, increased frequency in nocturia, and a tight band-like sensation around her mid-abdomen. On examination, there is slow detection of the left eye when looking to the right, diffuse hyperreflexia, decreased pinprick sensation up to the umbilicus. So the following is the likely diagnosis. So your options are adrenal leukodystrophy, CMV, polyradiculopathy, Guillain-Barré syndrome, multiple cerebral infarcts, multiple sclerosis. I'll give you a minute to solve this on your own. All right. So this is a typical case, as I would show you, not a difficult case. You need to remember that 32-year-old woman is the particular demographic in which this affects. A Caucasian 32-year-old woman is a typical demographic that you must keep in mind for this condition. And of course, the plethora of the symptoms that they have given, these are also important to know. So the key neurological findings that you must identify is number one, the sensory level to the umbilicus. Now, whenever there is a sensory level given, it means that there is a spinal cord lesion. So it could be transverse myelitis or any other spinal cord lesion. The umbilicus, you must remember, corresponds to the T10 dermatome. Now, intranuclear ophthalmoplegia is also given, as you could see that there is slow reduction of the left eye when looking to the right. Right, so this is intranuclear ophthalmoplegia, which means that the medial longitudinal fasciculus is affected, and this is classic for multiple sclerosis. So already we are halfway through, and there is also hyperreflexia, which is an upper motor neuron pathology, which is also consistent with the spinal cord involvement of multiple sclerosis. And also, a typical neurogenic bladder is also given. which is common in MS flares. So these are the key findings given in the question, and all of these are very, very important. Very high yield, you must know all of these. Putting it together that the patient is a young woman, has INO, has sensory level hyperreflexia, bladder issues. So this is obviously multiple sclerosis with acute transverse myelitis. Transverse myelitis because she has a sensory level, and transverse myelitis can occur in multiple sclerosis. Why are the other options wrong? Because adrenal leukodystrophy is X-linked, so it affects boys, not acute, and it also has no INO in its presentation. CMV polyradiculopathy occurs mostly in HIV and immunocompromised patients, and it causes hyporeflexia, not hyperreflexia. Guillain-Barré syndrome causes ascending weakness and areflexia, not hyperreflexia, and also has no sensory involvement and no INO. It has no sensory level indication. Multiple cerebral infarcts would not cause a clear sensory level. Again, it's a spinal cord problem. So the takeaway is that INO is multiple sclerosis until proven otherwise. INO is very classic for multiple sclerosis. Sensory level and bladder symptoms just support the diagnosis. So one point is that MS can produce both brainstem, which causes intranuclear ophthalmoplegia, and spinal cord lesions simultaneously. So you must know that intranuclear ophthalmoplegia is a brainstem problem, and sensory level is a spinal cord problem. So you must know this difference, right?